Hello everybody, my name is Iain Cranston. I'm an NHS physician based on the south coast of England. I do not work for Nemaura, but I think this is really exciting. We've got a CE marked non-invasive glucose sensor. And most of us working as clinicians over the course of the last few years have been dramatically changing our clinical practice based upon the information that we've got from some of the invasive sensors that we've seen over the last few years. So, my take on this is to say, which patient groups should we look as healthcare professionals to be encouraging this device to be used in, and perhaps at least as importantly as which groups of patients, how should we be looking to do that? So, quick background, I am a fairly long-standing now physician in type 1 diabetes for about 25 years. I've had a special interest in technology implementation around, and particularly technology implementation around avoidance of hypoglycemia since the early 90s. That has led me to be a fairly early proponent of structured SMBG and then CGM use over the last 15 years or so. And I am an exceptionally enthusiastic proponent of the idea of data-led consultations around diabetes-specific therapies, not hemoglobin A1C-led consultations. And I think that those of us practicing, particularly in type 1 diabetes, will recognise how important the data-led element of the consultation is. We can offer advice that we know will make benefit, not that might help. So for a number of years, I've also been an educator looking at how we use data more effectively in the consultation, and particularly, as you heard, how we use the ambulatory glucose profile with its creator, Roger Massey from IDC Minnesota. So having said that, I work exclusively in the NHS, which means I have to compulsorily be a realist about how we implement new therapies. The NHS is a really challenging workplace from the perspective of trying to get new technology involved. So I've taken the graphic that you saw from Fred's presentation and put a UK perspective traffic light on it in terms of how likely people are in those particular population groups to be able to receive reimbursed glucose monitoring strips as we stand. And in essence, as we can see, the left-hand end of this, from an NHS perspective, will not receive reimbursed monitoring equipment. The right-hand end absolutely will receive reimbursed monitoring equipment, and until relatively recently, the problem we had was that the right-hand end weren't accessing nearly enough data because of the challenges of how that data was collected using SMBG. But we now have appropriate data for many of our patients in the right-hand end of this scale. And I think we have to be realistic when we look at the population values that we see coming in around dysglycemia. These barriers to prescribed therapies aren't going to be broken down quickly because of the enormous expense involved in the larger population data. And we know, certainly until there is a major change in the invasive CGM market, that there will also be limitations at the right-hand end around how many and which groups of patients can receive invasive CGM monitoring. Although it is hugely beneficial almost across the board for those people that do. And we've seen a number of processes now, particularly in the UK, looking at pathway-based care around how we decide when people require CGM versus other technologies. And I think that all of those things are moving forward progressively. And what we then need to look at is how we then fix non-invasive CGM into that similar pathway process. So, a bit like flash monitoring 5 years ago, at launch, which in the UK is expected to be early 2020, this will be a self-purchase device. So it isn't expected at launch to have a reimbursable element, at least in the UK. So who will buy it? Because there are a number of fairly straightforward statements about if it's being self-purchased, it has to be somebody who has the money to self-purchase it. And they purchase it either because they've heard about it themselves or because somebody has told them about it and they decide they wish to purchase it. And I think what we have to then think about is where we as healthcare professionals sit in that, is this something we should be actively encouraging people to go out and purchase, even though it's not something that I can initially at least write on a prescription pad? Because we know that devices that are personally purchased the decision-making process is generally governed by what the individual spending the money believes to be the immediate benefit of purchasing. And so we know from a number of focus groups around invasive CGM that those people who went out and self-purchased in the first place did so to avoid the immediacy of having to do multiple finger sticks in a day. Having recognized that they were able to avoid doing finger sticks in the day, the other potential benefits of CGM but then became obvious to them. So our challenge as healthcare professionals is to say, what we know is likely to be reimbursed in a health system isn't generally something that is about short-term personal benefit. It's usually about long-term outcome-based changes. And so what we have to work out with this type of device is how we can support our patient groups to achieve longer-term outcome benefits with a device which is either relatively short-term or maybe intermittently being used, which of course is very different from what we've seen with the invasive CGM, with its trend over the course of the last 4 or 5 years to have longer and longer periods of continuous sensor wear. So, how would we work that best into which patient group? And actually, you won't probably be terribly surprised. I promise you I did not make my slides in any combination with Fred, but the groups where we have benefit for structured SMBG already documented are clearly the groups where we will expect to see early benefit from an intermittently worn CGM device. And therefore, I think it's sensible that we as healthcare professionals should support those particular groups to use it as rapidly as possible if they wish to improve their own control. So where are those groups? They're in the middle of the program there. And actually, what's important, I think, in that is that this is, as Fred has already mentioned, is at present a very underserved population from the perspective of use of data within their personal disease management structure. So we need to work out how we will better use that data. So, why do I think these groups particularly will benefit? I think the last 5 to 10 years has seen a really powerful move recognizing the importance of glycemia and consistent glycemia management in type 2 diabetes. And in particular, recognizing that glycemia management in type 2 diabetes may not just be a hemoglobin A1C reflection, but may absolutely relate to the overall profile that the individual experiences. As I've mentioned, and Fred also, the STEP study with Polonsky and the San Carlos study both showed significant outcome benefit for individuals using data more intensively compared with using data less intensively. So if we are able to incorporate intensive data into our clinical practice, we know that we can improve outcomes with that. The challenge, of course, that we've had, and I've been into numerous committees with this, is to say, it's fine in a research population to see people doing 3-day 7-point profiles prior to coming to a clinic to determine whether a therapy change is required. The challenge in real life is that when the person comes, they haven't done it, or they've actually only done 2 or 3 tests over the course of the 3-day period rather than the 21 that are expected. And it's effectively all down to this challenge of the reticence for people to undertake regular and invasive monitoring. The other reason I think is a practical one, that I think that this is an appropriate group to concentrate on. We know from invasive CGM that the glucose profiles of individuals can vary wildly. But actually the glucose profiles vary according to patient-specific aspects. And in particular, we would say that the group in the middle of that profile, those with type 2 diabetes on either oral therapies or relatively simple insulin regimens, have a much more predictable day-by-day profile. And I want to show you what I mean visually from that perspective. We have 2 ambulatory glucose profiles here, both produced with a Freestyle Libre. What we see on the left of this is a profile that shows clear in-day variability over a 14-day sensor wear period, but that each day of that 14-day sensor wear is fairly similar to previous days, in that the overall pattern and the day-to-day variability, or the width of the profile, is small. Did we need to wait 14 days to see what the pattern of this person's glucose experience is over 24 hours, or could we have told that from a much shorter period of time? In groups of people with oral and relatively simple insulin therapies for type 2 diabetes, the predictability on a day-to-day basis is far greater than what we see in people with type 1 diabetes. Now, I've done the opposite of what clinicians normally do when they come to present data in meetings. This is actually my worst profile that I have from my clinic at the moment, rather than one of my best. But the principle is those people with type 1 diabetes may actually have a not dissimilar average glucose, but the difference between one day and the next is far greater. So that the therapy change that's required for the individual with type 1 diabetes, in whom every day appears to be different, has to take into account the reasons behind every single fluctuation in glucose, and is a major re-education process often. Whereas the person on the left here, which is much more symbolic of most of the people that we see when we put profiles on to look at people with type 2 diabetes, is far more predictable and clearly shows us therapy mismatch at different times of the day. He is effectively being overtreated in the overnight hours and undertreated in the first part of the morning. So we can think of a very specific therapy change that would be appropriate for that person, whereas the person on the right, changing their insulin dose will make no difference to this profile, because it's all about a behavioural change that will impact that profile. So for many of our patients with type 2 diabetes on more simple therapies, this form of non-invasive continuous glucose monitoring, producing as it will rather less clear 14-day profiles perhaps, may well still be absolutely as predictive. And I want to show an example of this using some of the data from the SugarBeat. And what you have on these slides is the SugarBeat data in the red line and individual fingerstick data taken as the blue circles. And what you can see is on 2 successive days, although the 2 days are not the same, and we wouldn't expect them to be, the trend across the 2 days is the same. So that we don't need to put 14 days of data together so that we can determine where mismatch is occurring. And if I take a second example of the same thing, a different patient, but we see the same picture. We see exactly the same pattern occurring across the 2 days of the profile, although the profiles are not identical on the 2 days. So I'm very excited by the prospects of having a non-invasive glucose CGM. And the reason I am is because I think that it has the potential to be hugely beneficial, both, as we've heard, from the self-management, self-motivation perspective, but also from the perspective that we as healthcare professionals can offer better clinical advice to our patient groups. However, if we're going to do that, we have to learn how to use the data. And I think particularly what we need to do as clinicians with these tools is to work out the accepted process we have of producing an AGP, which is usually from a single sensor as a continuously monitored period. Can we get valid data, and if so, in which patient groups, from episodic single days aggregated together? Does that give us data that is as solid? And if so, which patient groups does it allow us to do that in? But I think from my perspective and from a prescribing push point, the clear logical focus for me is on people with type 2 diabetes who aren't well served at the moment by some of the technologies that are available.